Welcome to the American College of Cardiology's Conversation with Experts. We've got a great panel here. We're going to bring you the latest scientific information and really take a look at sort of the year that's gone by. And we're coming to you from the Heart Failure Society of America's 2013 annual scientific session. I'm Dr. Randy Martin. I'm glad you're with us, and I've got a great panel. I've learned a lot by just having a chance to chat with my esteemed colleagues. First, Dr. Clyde Yancey. Clyde is Chief of Cardiology at Northwestern University, the Feinberg School of Medicine. Dr. Marielle Jessup. Marielle is Professor of Medicine at the University of Pennsylvania, the Heart and Vascular Center. And Dr. Jim Janussi. Jim is Professor of Medicine and at the Harvard Medical School and the Director of the CCU unit at the Mass General. Great to be with you all. So I sort of teased a little bit there that we're going to look back, but a lot of very interesting clinical trials over the last year and a half. I've got a list of about 20. We're going to get to talk about 3. Marielle, tell me what would be one of the interesting ones for you.
Well, I think the one that people continue to talk about is the CARESS heart failure study. This really was a study done by the NIH Heart Failure Network, a conglomeration of heart failure programs sponsored by the NIH that gets together and really answers questions that need answering. And one that really needed answering was, what does ultrafiltration do for the patient with heart failure? And the way they set up the study is that patients that were refractory to their normal diuretics that required hospitalization were randomized to either IV diuretics or ultrafiltration. There was a protocol for ensuring that the IV diuretic prompted a vigorous diuresis, right. And they looked at the outcome. They looked at both weight loss and change in creatinine, and also looked at other events. It was much anticipated, and I will say it's because of a previous study done quite some time ago called the UNLOAD study. The UNLOAD study had a provocative finding that although there was better weight loss in the ultrafiltration arm, it was not a randomized trial. Readmissions were decreased in the arm of the patients that got ultrafiltration. So across the country and across the world, in fact, people have been looking at ultrafiltration. So the CARESS trial everyone was very interested. What they found out was not only was there really no difference in weight loss, both the regular arm and the ultrafiltration arm lost weight, but there was an increase in creatinine in the ultrafiltration arm. Moreover, there were more side effects, mostly related to the invasive nature of putting the catheter in. Yeah. Lots of controversy around that. It is not the last ultrafiltration trial we're going to look at. And I think many people were disappointed. It was a very focused patient population, and it may not necessarily answer the question about the role of ultrafiltration in a different kind of patient population.
Jim, Clyde, what are your thoughts about the CARESS HF study?
Well, I think it was the right kind of study to do under the right circumstances, because it answered the question regarding, as we would think we should use ultrafiltration, how does it work? And we've got an answer, and sometimes the answers are disquieting, but we have an answer done by careful investigators that needs to be respected.
Yeah, and I think the other thing is it gives a good framework for how to use diuretics and how to approach the patient with worsening renal function. One of the incorrect approaches I think we sometimes take is we dial back on the diuretics when we see worsening renal function, and the message from DOSE and from CARESS is that one needs to go to higher doses at times in these patients, twice the home dose IV, twice daily, in order to get a good diuresis, and the outcomes actually are favorable in these cases.
That's a neat point, and something that really comes out of this. All right, so that was the CARESS HF. Okay, give me another one, Jim. What's another one?
Well, for me, given my interest in biomarkers, a study focused on a drug called serelaxin. All right, one of 2 trials we'll talk about called RELAX was a really interesting study. So in patients with acutely decompensated heart failure, we have a long history, unfortunately, in the heart failure world of studies that have not illuminated a path forwards, largely due to either neutral results or actually increased risk, right? With inotropes, for example. So serelaxin, or relaxin actually, is a hormone that circulates in every pregnant woman. It's a hormone that the body uses to increase the cardiac output, and vasodilates, and may have some peripheral effects on tissue laxity to allow for delivery.
Sure.
But the main focus has been on its hemodynamic effects, and if you consider that we have a large body of safety data now, given the fact that this hormone is actually present in every pregnant woman, it's been harnessed now for heart failure therapeutics. And indeed, it does increase cardiac output, it vasodilates, it afterload reduces. And one thing that has been noticed that I think has caught the attention of a lot of us is that it doesn't seem to activate the renin-angiotensin-aldosterone system. So in a study that was presented not long ago, the use of relaxin in the form of serelaxin, a recombinant version of the hormone, was given to patients with acute heart failure. And what was found was that it reduced dyspnea, which was really the primary focus.
Sure.
You know, people can argue about dyspnea as an outcome measure in trials. It improved dyspnea. Interestingly, when you look at the short-term outcomes, 60-day outcomes, there was no real difference between the two groups, although one could argue the curves were diverging in this relatively small trial. But in longer term, there was a substantial reduction in really major adverse cardiac events. In parallel, something that I find very attractive about this drug is that if you look at the various biomarkers of adverse outcome, whether we talk about troponins, natriuretic peptides, hepatic dysfunction, renal dysfunction, they all tracked with the benefit of the drug. So patients treated with serelaxin were less likely to have a rise in their troponins, less likely to have an inadequate fall in their NT-proBNP values. And so this sort of pan-organ improvement seemed to support the longer-term adverse events that this drug seemed to reduce.
How's it given?
It's intravenous.
Okay, Claude, what are your
So
thoughts?
a couple of things that Jim brought to bear that we should focus on. It is correct that this favorable biomarker panel really supports the notion that something good is happening. But what's really important about this study are several other features. The first is that therapy was started quite early, within just several hours of getting to the emergency department. Was that part of the benefit, starting right away?
Yeah.
Right.
The second thing, and this is incredibly important, the patient population had to have a minimum systolic blood pressure of 125 millimeters of mercury. We've been saying all along that those patients that come in the hospital with heart failure are very diverse, very diffuse, lots of different phenotypes. So this may be the first real step forward of parsing out which patients respond to which therapies, and will give us a bit more precision on deployment. And then finally, and maybe this is my age creeping in, we should always be a little circumspect about really dramatic findings on outcomes in studies that are not as robustly powered to deliver those outcomes. It's good enough in my mind that it relieves shortness of breath, relieves dyspnea without harming patients. I hold judgment a little bit about these important outcome benefits.
Yeah, I mean, the big trials are coming, and that, you know, we're all crossing our fingers we see similar outcomes.
Yeah.
Marielle, your thoughts on this, on the Relax HF?
Yeah, I'm the sadder but wiser girl because I've been down this pathway many times, getting very excited about preliminary findings of a drug. So I'll temper my enthusiasm until we see, you know, we really see the meat, which is the next trial.
All right, so we've got two people that are cautiously optimistic, and Jim presented a great case. You're optimistic, but I think also cautiously optimistic. Clyde, that leaves you. Tell me the trial that struck your fancy in the last year.
Well, there's another trial done by the Heart Failure Network called Relax, and it really points out the advantages of having a group of engaged collaborators that are willing to take on important questions that wouldn't otherwise be addressed. So this study looked at patients with heart failure and preserved ejection fraction, a very challenging group of patients, and looked specifically at those that had an elevated biomarker to demonstrate that they were symptomatic, BNP or NT-proBNP, but also thought of using a compound, sildenafil, a PDE5 inhibitor, that would actually modify pulmonary vascular resistance and pulmonary artery pressures. Many of us empirically have thought, not a bad idea.
Yeah.
Let's
Right.
It
try
may,
and give this.
may impact remodeling as well. I mean,
Exactly.
there's all sorts of rationale.
There should be some
Truly
benefits.
a vascular disease.
Exactly.
Right.
Yeah, because we're still trying to argue about the pathophysiology of HFpEF anyway. Is it a ventricular problem, a vascular problem, a cardiorenal problem? Nevertheless, a study was done, and we were disappointed that we didn't see a real signal of benefit here. It doesn't mean that there's not potential to continue to modify phosphodiesterase as an enzyme that's participating in the pathophysiology, but it does say that perhaps we haven't found the right way to do it yet, and we should continue to think about that. But I think every time we delve into HFpEF and get an answer, even if it's a negative answer, it gets us one step closer to a positive answer. That's my best way of being optimistic.
That's a good way to look at it.
Well, I think you touched on one of the problems earlier. We've taken patients that have heart failure and thrown them into one big bucket.
Absolutely.
And they're not. I mean, why would you put everybody that has cancer into one bucket? We've learned that you need biomarker information, you need genetic information, you need phenotypical information to treat cancer. We need to do that in heart failure as well. So probably treating HFpEF has been a failure because all of these people that have HFpEF are very different. And we are going to have to get smarter at parsing out the subpopulations, like we're beginning to do in HFrEF, of understanding that ischemic HFrEF is different than idiopathic. Women with left bundle branch are different than women without left bundle. And we're going to have to do that with HFpEF as well.
Yeah.
But
no, I mean, I'm bullish on that idea, obviously, because of biomarkers and how they might impart information about different types of patients. I'm also still bullish on PDE5 inhibition. I have to say, I've had patients that were randomized into these trials who spread their wings and felt great when they were on study drug, and when the study was over and they withdrew the drug, they fell to pieces. And so I do think there are subgroups that will benefit from these therapies. The real question is how to identify them. I mean, HFpEF, more than a group of patients all with myocardial infarctions, is a totally different animal. I mean, there are so many different causes of heart failure with preserved EF. There are the rare patients who have, not so rare actually. There are patients who are out there who have pure heart muscle disease.
Right.
There are patients who have mitral regurg. There are patients who have atrial fib. I mean, there are so many ways that HFpEF can occur.
I mean, it's a very difficult thing to treat. I mean, again, for the non-heart failure cardiologist, I mean, because exactly what you're saying, there's so many different etiologies, there's so many causes. Is his optimism for these phosphodiesterase inhibitors warranted in this?
I think his optimism that we can better identify patient groups is totally warranted. I'm not so certain about the PDE5 inhibitors. Maybe we will find better strategies for this problem. But I think what's really important is to tap into something that Marielle suggested. This is hard. I mean, it's really hard. We've looked at angiotensin receptor antagonists and we came up empty. Now we've looked at PDE5 inhibitors and we've come up empty. We're anticipating information soon about aldosterone antagonists, although we have some preliminary data using aldosterone antagonists that maybe so, maybe not. So I think, to Marielle's point, we really have to understand more about the biology and more about the different patient groups. Otherwise, the frustrations will continue.
Good. Well, these excellent points. Very good clinical trials, good discussion of these. And I mean, I like the fact that you really highlighted that if a trial comes out negative, we still negative in an endpoint or negative in long term, we're still learning a lot, going back to the ultrafiltration, the diuretic dosing and all that. So it's very important for a non-heart failure cardiologist, very encouraging to sit here and listen to you all and learn from you. And again, I compliment the society. You all have done a great job in putting teams together and really looking at a team approach to managing the patient, communicating with the patient. So you've communicated with us and you've communicated with our audience. We thank you for joining us. I've learned a lot. I hope you have. Thanks very much.